Good morning. We'll study the slides of the female genital tract system so that you can be ready for the end-term practical exam, the optional. Now, this is a biopsy from the cervix, and we have to evaluate the maturation of the squamous epithelium. So, have a look at this power field. Do you see any difference? In this image, is the epithelium the same throughout its length, or do you see something that is abnormal? What do you think? How do you understand the maturation? The maturation of the squamous epithelium is the acquisition of eosinophilic cytoplasm as cells leave the basal zone and go in the upper layers. So, in this field, we can see that there is some maturation here, you see. However, this maturation is not evident in this part. So, this is consistent, compatible with the high-grade SIL. That means there are atypical cells occupying more than 2/3 or the whole thickness of the squamous epithelium. The question is the adjacent epithelium totally normal, or is there some low-grade dysplasia in the adjacent epithelium? So, if you look at these cells here, squamous cells here, what can you say with regard to their cytoplasm? What can you say? Yes, please.
The ratio of the cytoplasm to the nucleus is not as small as one.
This epithelium, is it as dysplastic as this one? It's not as dysplastic. So, the question is, it is either totally normal and maturing epithelium. However, there is some sort of chelocytic change in this epithelium. That means that the cytoplasm in the upper layers is not eosinophilic as normal, but it is empty somehow. It appears to be clear. So this is some sort of chelocytosis. And if this is related with some shrinkage of the nuclei, then we might diagnose low-grade SIL. The question is, are these nuclei typical of chelocytes, meaning that there is HPV infection? Or is it just an accumulation of glycogen that gives the cytoplasm of these cells this clearance? It is not always an easy question to answer. However, you should bear in mind that in low-grade squamous intraepithelial lesions, we can see the chelocytes. Are you okay now? Yes. Yeah. We can see the chelocytes, and the evidence of HPV infection is the presence of nuclear atypia, not just the clearance of the cytoplasm. It is not enough it is not an adequate indication of HPV infection. So, in this area, you might say that, have a look at the parabasal cells. There is somehow a loss of their orientation as they go up. That means there is not a very definite polarization of the nuclei as they go up. So this is consistent with low-grade dysplasia. However, this area here, where we have increased nuclear cytoplasmic ratio, is compatible with high-grade dysplasia. In high-grade dysplastic epithelium, of course, HPV has entered the genome of the cells. However, it is no longer morphologically identifiable. That means when you see the chelocytotic atypia, this is consistent with low-grade dysplasia. When you do not see chelocytes, atypical chelocytic cells, but however you have evident dysplastic morphology of the nuclei, this is consistent with high-grade squamous intraepithelial lesion. And of course there is a clinical significance in this distinction, because if the woman has low-grade dysplasia, you do nothing. You do nothing. You just have the follow-up and you check with pap smears to see if there is some progression from low-grade squamous intraepithelial lesion to high-grade, because this is the more imminent of invasion, high-grade dysplasia, high-grade squamous intraepithelial lesion. So if you have on histology, on the biopsy, low-grade, you just do the follow-up of the patient. And perhaps the patient will send the virus away on its own, the organism on its own, and provided that there is some degree of immune competence. That means you could do something to reinforce the immunity of the patient, and she'll send the virus away. However, if you have high-grade dysplasia, then you have to do a surgical procedure, but not radical. Why not radical? Because since there is no invasion, there is no risk of metastasis. So there is no point in resecting the uterus, because this is what we do when we have invasive carcinoma. And the invasion should be more than 5 millimeters in depth, because in the other case, we have microinvasive disease. That means we have invasion in less than 5 millimeters, so you treat it as severe dysplasia, as high-grade SIL or in situ carcinoma. So, if you have high-grade dysplasia, you have some sort of conal excision of the mucosa, and in these specimens, you have to check the margins. If the margins are dysplastic, then there is an increased risk that the patient develops invasive disease. If the margins are free of dysplasia, then that's enough, that's okay. There's no problem with the patient. So this is the treatment of low-grade SIL when we have the atypical cells in the lower third of the epithelium, and where we see chelocytic atypia. This is low-grade conservative treatment, just follow up. And the other is high-grade SIL, where we no longer see chelocytes. However, the HPV has entered the genome of the cells, and you see atypia in more than 1/3, and most often in the whole thickness of the squamous epithelium. This high-grade dysplasia requires conservative surgery, okay? Because you have to remove the dysplastic, the severely dysplastic area, so that invasion does not develop. Yes?
So for high-grade, you see the HPV inside, like
It is inside, yes, but you no longer see the chelocytic atypia. However, it is an HPV-related lesion. But when you see the chelocytic atypia, this is consistent with low-grade.
And you see an increase in the nucleus.
And you have the increase in the nuclear size in an increased thickness of the squamous epithelium. Always more than 1/3. So, another interesting feature is this. Here is another case where you see high-grade SIL, no evidence of maturation, and no chelocytic atypia. And it is of interest that you look at the glandular component of the mucosa. You see these glands here, which appear to be in the lamina propria, because since we have the two dimensions in the slide, we cannot see the continuity to the surface. And what's the problem here? The problem is that I want to show you this image, this slide. Look here. Here we have the dysplastic epithelium, okay? And here you have the cervical glandular epithelium. So, what is there? If you see these formations, solid formations, and here you can see the lumen as well, it's not solid. However, if dysplasia enters this part of the glands, because if you have the glandular epithelium in the lamina propria, and on the surface you have squamous epithelium. How is this called? How is this called? This is metaplasia, squamous metaplasia. So, in case we have dysplasia, and particularly high-grade SIL, what can happen? The metaplastic epithelium, which appears to be in the lamina propria, may become dysplastic, as the surface epithelium, affected by high-grade SIL. So, what is the risk of misdiagnosing here? If you see formations of atypical cells within the lamina propria, what might you think there is? What do you think? Which will be an overdiagnosis. Yeah. You can misinterpret it as invasion. So what is the clue that these cells are not invasive, despite the fact that they appear in the lamina propria? The key point here is the smooth margin of the solid formation. You see how smooth the margin is? Look, it's very, very round. And furthermore, there is no desmoplastic response nearby. That means that the lamina propria between these solid formations is normal. So we can understand that this is just participation of the endocervical glands in the metaplasia and in dysplasia. And it is not frank invasion. On the contrary, in the other slide here, you can see the superficial epithelium with high-grade SIL or in situ carcinoma. These are too close. However, look here, what's going on. Look at the margin of these downward proliferations. It's clearly irregular. And furthermore, you can see that the stroma between these formations of atypical cells is clearly desmoplastic. So this is a sign of true invasion. In this case, you have to perform uterectomy and remove the whole uterus with all the surrounding fat tissue, because you have to look there for lymph nodes and see if they are metastatically infiltrated, and you have the staging, the pathologic staging of cancer. So this is how we discriminate true invasion, like this field here, from participation of the endocervical glands in high-grade dysplasia. Is that understood? Okay? So what else do we see here? We look at the invasive component of the tumor. Here there is some sort of necrosis. We have the atypical cells. What are these that I show you? Since these are cancerous cells, they have increased. What are they? Look. Here, 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 here. What are they? Increased mitosis. Okay. Increased mitotic activity. And there is some degree of pleomorphism, of course. So how can I tell that this is squamous carcinoma? Okay, there are some solid formations. Some places look, this karyorrhexis here. There is some degree of eosinophilic cytoplasm, which is consistent with squamous cell differentiation. However, this is rather poorly differentiated. That means high grade, because, okay, you can see all the mitotic activity. However, here, look, this may be dyskeratosis. That means apoptosis in a single squamous, malignant squamous cells, which is evidence of some sort of keratinization, dyskeratosis. And when we look at the other invasive cervical carcinoma, here this is somehow better differentiated, because we can see that there is enough cytoplasm. And what else can you see? Look here, that this is consistent with squamous cell differentiation. What can this be that I show you? And we always look for it in the slide, because this proves that these malignant cells are squamous cells. What are they? Yes, please. What are these small junctions? The hemidesmosomes, that's right. These are the bridges, the intercellular bridges that only squamous cells have. Only squamous cells have, and they join one to the other. It has these bridges, and this is a sign of squamous cell differentiation. However, this tumor is devoid of the most typical sign of keratinization, which is what? As we have seen in other carcinomas of squamous cell origin, the keratin pearls. There are no keratin pearls here. So it is not well differentiated, because if it were a well differentiated carcinoma, it would form many keratin pearls. Here we have evidence of keratinization, but in the form of dyskeratosis. That means keratinization of single squamous malignant cells. And we have the intercellular bridges, which is also a sign of squamous cell differentiation. And what else can we see in the invasive squamous cell carcinoma? We can see how deep it goes to the wall of the cervix. Which layer is this one, which is invaded by the cancerous formations? And look how irregular their contour is. See how irregular it is? So which layer is this? Because this is a feature for the T staging, the pathologic T staging of the TNM staging system. So which layer is this pink here layer forming bundles of pink cells, which is invaded by the squamous cell carcinoma? The muscular layer. So it is quite deep. Invasion has been quite deep in this carcinoma. And furthermore, have a look what has happened to the superficial mucosa. Look, are there any squamous cells here? No. There is an area of hemorrhage. Look here. Here you can see the mucosal squamous epithelium with all its layers, stratified epithelium, and here you do not see the epithelium. So what has the cancer caused as regarding the surface epithelium in this slide? What has it caused? Since you see that there is destruction of the covering epithelium, yeah, an ulceration. So as I told you, if you see an ulcerated lesion in the covering epithelium of the skin of the mucosa, you have to take biopsies because ulceration may be caused by invasion, by cancer, true cancer, invasive cancer, or it can be caused by inflammation. So you have to tell what's the cause of the ulceration. That's why you take biopsies. And you look it under the microscope. If you see malignant cells, you say, it's cancer. Cancer has caused the ulceration. If you just see the inflammatory exudate, you see it's some sort of ulcerative cervicitis, inflammation of the cervix. Yes, yes, please. This keratosis is keratinization in single malignant cells. And how do they appear? Since they have entered the apoptotic process, the nucleus is very shrinked and hyperchromatic because this cell has entered the apoptotic procedure. And the cytoplasm is too pink, too oxyphilic. It's somehow bright. So that is this keratosis, and it is evidence of keratinization, very helpful in poorly differentiated carcinomas. So, can you show me where the dyskeratotic cells are here? Have you understood this very difficult feature, the difficult feature of the carcinoma? Can you show me? Where are they? You see a very dense cytoplasm. That's the one. This one, these are the dyskeratotic cells. It is single cell keratinization. Here, you see? This is dyskeratosis. Okay. So, now we have the uterus, and we can see in the wall, in the uterus wall, these nodules, which are composed of cells forming interlacing bundles. You see? Have a look at the nuclei in these bundles. The nuclei is spindle. So, spindle morphology in the nuclei is consistent with which origin of cells? Yeah. The fibroblasts, yes, mesenchymal cells. Okay. Since this could be a fibroma, if those were fibroblasts, however, fibromas are not common in the uterus wall. The much more common and maybe the most common tumor is of benign nature and is composed of other types of cells with spindle morphology forming bundles, other types of cells. Which are they? Smooth muscle cells. So this is a fully differentiated tumor. Why do I say completely differentiation? Because they look just like the myometrium, which is right adjacent. It has the same morphology. So this is perfect differentiated, full, complete differentiation, because this is a benign tumor. So there is no evidence of dysplasia here. There is no malignant potential in this tumor, and it is composed of mature smooth muscle cells, and thus its name is leiomyoma, which is dependent on hormones, so it can grow always in a pushing fashion with a smooth contour. Have a look how smooth the contour of these leiomyomas is, multiple leiomyomas, and since they grow, they may cause problems, especially they will press the cavity of the uterus, so there will be problems of maintaining a pregnancy. Or if they become big enough, they can cause bleeding because they will press the endometrium, the mucosa, and it will fall, it will break. So this will be consistent either of menorrhage, that means increased blood in the menstrual cycle, or you can have this blood irrespective of the menstrual cycle. So this is why when leiomyomas are multiple, as here, because you see there are many nodules of Schmathel cells, you're thinking of either resecting the leiomyomas on its own, and here you have to say if it is within the wall, if it is right under the mucosa of the endometrium, or if it is near the serosa, and you have to resect them because they may become big enough and cause all these problems by compression. So these are totally benign. They may have a component of fibrous tissue. However, their derivation is of smooth muscle cells, not fibrous cells. So these are the uterine leiomyomas. It's very easy. You see the bundles of the interlacing bundles of smooth muscle cells, very similar, identical, I would say, to the adjacent myometrium. It's just the same. However, you can see that this is a tumor, and if you put it under the microscope, you cannot tell that this is a tumor because it is fully differentiated. It looks like normal myometrium, but you have the macroscopic evaluation where you see that this tissue forms nodules. So you can understand that this is a tumor, or at least a tumor-like lesion. Okay, next. We'll look at this part, this section here. I can see some parts of the wall, some of the wall of the uterus, and everywhere we have the bundles of smooth muscle cells in the myometrium. However, here we can see something that should not be there, should not be in the myometrium. What tissue is this? What tissue is this? Have a look. What are these structures here? Can you tell me? What are these structures? Identify this tissue. Tell me. Identify this tissue. What are they? Yes, that's right. Which tissue is this found in the myometrium? Glands. Yes, these are glands. So if you see glands in a wrong place, you might think that it is invasion. It's not the case here. Why? For two reasons. The glands look totally like the normal glands of the endometrium, proliferative type. That means the first half of the cycle. And furthermore, and more importantly, apart from the glands within the myometrium, you see totally normal endometrial stroma, and not the desmoplasia that cancer could have caused if it were cancer. So, how can you make the differential diagnosis between an ectopic presence of endometrial tissue and cancer? You see the stroma. If the stroma is normal, cancer is ruled out. And why do I stress the stroma so much? I stress it because there is some sort of atypical hyperplasia of the endometrium, which looks like cancer, endometrioid type, as we said in the lesson. That means hormone-dependent cancer of the endometrium. So in this case, that atypia is present. If you see atypical glands within the myometrium, you might think that this is invasion by an endometrioid endometrial carcinoma. No. If you see normal stroma around these glands, it's not cancer. It's just ectopic presence of endometrial tissue. So it's a benign lesion. And if you see these glands outside the uterine, either in the peritoneal cavity or forming cysts, chocolate cysts in the ovaries, because this ectopic endometrium follows the hormonic continuity of the cycle and bleeds like the normal, the the orthotopic endometrium. So it may cause problems, fertility problems, because in areas of hemorrhage, you may have macrophage and you may have fibrosis. And if this affects the salpinx, then they will become stenotic. And that can be a cause of infertility. So how is this called? The presence of endometrial tissue, but not in the wall of the uterus, not adenomyosis as here, but outside the uterus. How is this called? Yes. So you want to be a surgeon, I see. You know, surgeon, you have gynecology surgeon. Very good, very good. That will be endometriosis. All right? Endometriosis. Ectopic. Outside the uterus, presence of endometrial glands and stroma. I insist, and stroma. That proves that it is a benign lesion. Now, here, we have the endometrioid type of endometrial cancer. You see, glandular formation, glands, okay. There is atypia in the nuclei, increased size of the nuclei. However, look here. Now, how can you tell? That's what I told you before. Why are these? You see here the myometrium, see the bundles of the myometrium, and you see these glands. The glands are atypia. What will rule out the diagnosis of an atypical hyperplasia of the endometrium on sites of adenomyosis? The cells are atypical. They are just like cancer cells. But if it were atypical hyperplasia in a focus of adenomyosis, then what would be around these atypical structures? Normal stroma, which is not the case here. Remember how the normal stroma of the endometrium looks like? Do you remember? Let me show you. So have in mind what this tissue looks like. How would you describe this tissue? Look, look, look here. Look, look, look. Look. What is this? This is what cancer causes. This type of stromal reaction is caused by cancer. And have a look in the previous slide how normal stroma looks like. Look, this is normal stroma. That's why we call it adenomyosis. This is the desmoplastic reaction around the atypical glands. Look, is this normal stroma as I previously showed you? No. This desmoplastic reaction is consistent with invasion. So this is true carcinoma of the endometrioid type. That means hormone dependent, because as far as endometrial cancer is concerned, you have to see if it is hormone dependent or hormone independent. If it is hormone dependent, as the case here, you have the endometrioid type, which can be of low grade, intermediate grade, and high grade. It depends on how much of the tumor is occupied by a solid non-squamous component. This is the criterion to grade endometrioid carcinoma. If you have non-hormone dependent endometrial cancer, the most common types are serous carcinoma of the endometrium, serous endometrial carcinoma, and clear cell carcinoma, where this is a different type of cancer because there is no hormone dependence in these histologic types of endometrial cancer. So here we might say that this endometrial carcinoma is of low grade because I barely see any solid component in the tumor. I'm not I'm not sure. Yes. So this is a low-grade endometrial cancer, and it invades, let me have a look, about half of, if this is the myometrium, I'd say less than half perhaps. This is important for the pathologic staging of the tumor. That means the T parameter of TNM stage. And now we'll have a benign cystic tumor of the ovary. Here are the cysts, and here is the epithelium that lines these cysts. Totally benign glandular epithelium, because you have the nuclei close to the basement membrane. And can you identify the type of this epithelium? Can you identify the type of this glandular epithelium and tell me in which part of the female genital tract is it encountered? What, you see, it has some sort of droplets. You see some droplets in the cytoplasm? In a glandular epithelium, when you see these droplets, what can it be? What can it be? If you have a glandular cell and it has these small droplets in the cytoplasm, as here. It's totally benign and fully differentiated because this is a benign tumor. You see these droplets? What can this be? Mucus. So it's a mucinous cystadenoma. It is cystic in its configuration, deriving from glandular epithelium, thus we call it an adenoma, and we call it mucinous adenoma. As far as ovarian tumors are concerned, those deriving from the superficial mesothelial lining of the ovaries, now known erroneously as epithelial tumors of the ovary. This is how we classify them. Actually, it's not epithelial, but that's the way it goes. So we have serous epithelial tumors and mucinous epithelial tumors. Both have totally benign counterparts called serous adenoma, cystadenoma, because they are cystic, and mucinous cystadenoma, borderline lesions with some papillae and some complex architecture, which has to do with a potential to invasion and malignancy, and frankly invasive serous carcinomas, cystadenocarcinomas of low grade or high grade, and mucinous adenocarcinomas. If you have a serous cystadenocarcinoma, it is most often bilateral, quite often bilateral, and it is very frequently associated with peritoneal invasion. So these patients with primary serous adenocarcinomas of the ovary have ascites as a presenting symptom. That means accumulation of fluid within the peritoneal cavity due to cancer invasion of the peritoneum. This is what serous adenocarcinomas do. When you have mucinous adenocarcinomas, they are more common unilateral, not bilateral, and they rarely spread outside the ovaries. So they rarely form mucinous or gelatinous ascites, rarely by primary tumors, mucinous carcinomas of the ovaries. So if you have this mucinous ascites, it is not likely that it has to do with a mucinous cystadenocarcinoma of the ovary. What is the much higher possibility? Where could a neoplasm be and cause mucinous ascites? Where? Where can this be? And have the spread in the peritoneum, and you'll have ascites, and the fluid will have mucus. It won't be serous. It won't be an exudate like the serous cystadenocarcinomas. Do you know which organ? You have to look very carefully. And in this case, despite all this invasion of the peritoneum, there is a possibility that the tumor looks totally benign, totally benign. Can you tell me where it may derive form and produce mucin? I don't think it's so difficult. Since it is mucin-producing tumor in the abdomen, where may it rise from? The intestine, and particularly the appendix. The appendix, because these are known as LAMN, that means low-grade appendicycal mucinous neoplasms. They may look totally benign, however, they can spread away from the appendix and have all these implants in the peritoneum and cause mucinous ascites. So, in case you have mucinous ascites, before diagnosing a primary mucinous cystadenocarcinoma, have a look at how thick the wall of the appendix is, because the tumor may arise from the appendix. And another type of ovarian tumors are the metastatic tumors, most times deriving from the stomach. These are diffuse, high-grade gastric adenocarcinomas, which can spread to the ovaries, metastatic spread, and these are known as Krukenberg tumors. So, and they involve the peritoneum as well. So now let's have a look at the serous adenocarcinoma of the ovary. It most common forms these structures, which now that you are experts in pathology, I'm sure you will identify them. What are these structures here in this tumor? Look, they are very common in many. You can identify them in many. What are these structures? There are some solid, there is a solid component here, a glandular. However, in many areas of the tumor, here I'm sure you'll find this. Look, look. What are these structures here? Look, they are finger-like, and they have some true stalks. Not always true, but they have some stalks. I'm sure you know, because now you are experts. You have become experts in pathology. Experts. Do you know these structures? Have some orange juice, you know now, because it will be cold. Okay? To strengthen your immunity. Okay? Who knows that? Okay. The papilla. Yes. So it's a papillary cystadenocarcinoma. It can be cystic, it has papillae, and it is malignant. So it is a carcinoma, epithelial neoplasm. And sometimes we have psammoma bodies deposition. Not always, but sometimes you can see calcium deposited in these serous carcinomas. Let me see if there are any psammoma bodies here. I'm not sure. That's not always the case. However, you may find them. So these are the tumors we can spread easily in the peritoneum and cause ascites. Serous ovarian cystadenocarcinomas. And you can grade them as either low grade or high grade because they have different precursor lesions. These serous cystadenocarcinomas of the ovary have low grade and high grade, and they are of different, each one of them has a different precursor lesion. Okay. So, bear in mind that there are other tumors of the ovary as well, deriving from sex cord, and in any cases, if these tumors are accompanied by estrogen production, this may appear with hyperplasia or even endometrioid cancer of the uterus. If you have estrogen production by an ovarian tumor, the endometrium may become thickened, in the context of hyperplasia, or even malignant causing the endometrioid type of cancer. So those were the cases. Thank you very much.